Thanks everyone for joining us today. This is the first of three pieces of analysis that we'll be sharing with the network over the next couple of months. Our colleague Andrew Jones is working on a piece of work which will examine the consequences of expanding diagnostic capacity, some of the unintended consequences maybe of expanding diagnostic capacity. And Paul Seamer is doing a bit of work to examine which clinical cohorts and patient cohorts have suffered the most, I guess, during the COVID period, and the patient cohorts that we really need to pay attention to over the next 12 or 24 months to make sure we get them back on track and deliver services to them to meet their needs. These are people who have lost out really because lots of health services were shut down over the COVID period. But this report is about inequalities in access to planned hospital procedures, and it follows on from a report that we produced last year. We released a report about this time last year which looked at socio-economic inequalities in access to planned hospital care. The report examined primarily the causes and consequences of these sorts of inequalities. I'm just going to run through the headlines from that report just to remind you what we concluded last time we looked at this issue. So we found that people living in more deprived areas had poor access to planned hospital care, poor access to elective operations and day cases and outpatient procedures and outpatient attendances, for example. The effects were substantial, they were widespread, and they were worsening. And at least with respect to the pathways that we examined in detail, we found that those inequalities persisted even after carefully controlling for need. We found that the inequities tended to emerge towards the end of care pathways after patients were referred on to secondary care. And when we tried to look at why we've seen a deterioration in inequity over the last 20 years or so, we concluded that successive policy initiatives which were designed to improve or control access to planned care, waiting list targets, procedures of limited clinical value policies, NHS funded access to private hospitals, independent sector treatment centres, screening programmes, etc. They all may have been successful in their own right, but they seem to have systematically favoured people living in more affluent areas, and taken together, they serve to increase a gap or open up a gap between the rates of access for people living in deprived and more affluent areas. And the final sort of conclusion from the report was that we found that comparatively poor access to planned hospital care for people living in deprived areas explains, at least in part, why that group have got elevated rates of access to hospitals in an emergency. So that was the report we looked at last time. It was primarily focused on questions like what's the problem, where do we see it, why are these problems emerging? And it's only really after we published the report and we started thinking about the consequences of it that we realised just how hard it might be for an ICS or an STP to try and tackle this issue. It's really not straightforward to work out how you go from this information to a credible approach to address it. And so the Midlands Decision Support Network asked us whether we might do a follow-up piece of work to try and help people through that process, to guide people through that process of developing a coherent and credible strategy to address this issue. So that's where this next report comes in. It answers the question, so what do we do about it, and how do we address those questions? You might notice there's a subtle difference in the coverage of the two reports. So this second report just focuses on inequalities in access to planned hospital procedures. So it deals with surgical procedures and diagnostic procedures, etc., but not with more traditional outpatient attendances. It focuses more on the delivery end of a care pathway. Just one other thing, that the previous report predated COVID, not in its publication date, but the analysis all predated COVID, and that was partly deliberate, partly forced on us by the data availability, etc. So we wanted to start this report by just giving a little bit of an update on what's happened since 2019, since 2020, when the previous report stopped its analysis, really. So what has been the impact of COVID on activity rates and inequities? Well, I think the impact on activity rates are pretty widely reported. before COVID, activity rates have been rising by, a % or 2 each year, maybe slightly more in some years. And then COVID came along and activity rates really dropped off a cliff at that point. Intentionally so, we decided not to create risks by bringing people into hospital to do elective procedures on them when we weren't sure what the consequences of COVID infection might be. We were also trying to reserve capacity for the urgent consequences of COVID infections. But activity rates really fell quite dramatically in the first few months after the pandemic, and taken as a whole, the activity rates in 2020 were substantially lower than they were in 2019. They recovered somewhat in 2021, but still well below the figures that we saw in 2019. And I think people are familiar with that story. There's another angle to this, is what happened to equity as COVID played out. Well, trends in equity have been getting worse for some time. We've moved from a situation in the early 2000s when activity rates favoured people living in more deprived areas, to a situation in 2019 where activity rates substantially favour people living in more affluent areas. And what happened during COVID was that got worse. There was a step change in inequities during that period. So we cut back on care considerably, but we cut back care mostly for people living in deprived areas. And there's a question about how or why that came about, but that seems to have been the consequence. There was a bit of a recovery in 2021, but I think you could see 2021 as being on the trend prior to COVID. So I wouldn't see that as success necessarily. I think that's a continuation of the pre-COVID trend. The NHS England's strategy for addressing the backlog caused by the reduction in elective activity during COVID was published a month or two ago. And the sort of headline target in that is that they want to see a 30% increase in activity by 24-25 relative to the bits of activity in the pre-pandemic period. An incredibly challenging target, given where we are at the moment. At the moment, we're still struggling to deliver activity beyond the level that we saw before the pandemic. And the policy sets out various approaches to try and address the backlog issue, primarily surgical hubs and community diagnostic centres. And so we can see quickly how that might have an impact on this problem, the problem of reduced activity and the associated backlog. But I'm not quite sure I understand yet how that strategy will address this problem of inequity, the long-term trend, but also the COVID blip in inequity that we saw. It's certainly possible, I think, for those two things to be compatible, but I think that will take careful design, and I'm not quite sure we've done all that thinking that we need to do to make sure that when we recover the backlog, we do so in a fair way to try and address inequalities as well as just the scale of the backlog itself. So before we move on, I just want to make sure we're all on the same page in terms of equity, make sure that it's going to be critical that we all understand that issue in the same way. So I'm just going to describe what we mean by equity a little bit and maybe talk about how we might get there from where we are at the moment. So let's imagine we have 5 subpopulations, A, B, C, D and E, each of different sizes, and the health needs of those populations might be different as well, different age profiles, different disease profiles, etc. And let's imagine we're trying to think through what the needs of those populations are with respect to a particular planned care procedure, hip replacements or cataracts, for example. Let's imagine the need for those interventions is profiled something like this across the 5 subpopulations. And by need, I'm talking here about the ability to benefit from those interventions. Now imagine supply for those interventions looks something like this. So as we deliver services to the 5 populations, we do so in these volumes as distributed by those turquoise bars. So what we can see is that the distribution of supply for this hypothetical procedure follows the distribution of need. And so in each population, the ratio of supply to need is the same. That's what we mean by equity. The supply of services should follow patterns of need. And an individual living in population A who needs the intervention should be no more or less likely to receive that intervention than a person living in population C or D or E, for example. That's the case with this distribution of supply. Now let's imagine another situation where we have the same profile of need, but much lower levels of supply. But the levels of supply are still distributed in line with the levels of need. So we still have equity here, lower levels of supply, but still an equitable distribution of supply. Let's imagine this situation where we have the same pattern of need, but all the 5 populations are receiving the same quantity of a certain service. So this might at face value look as if it's fair, but it isn't fair because it doesn't follow patterns of need. And so you get an uneven distribution of supply to need ratios. Person living in population E here is much more likely to, who needs the service, is much more likely to receive it than a person living in population C who needs the intervention. And in this last scenario, we get another distribution of supply, which is also inequitable. And I want to go on to think about what it would take to move that distribution of supply to an equitable distribution of supply. How do we get to equity from that distribution of supply? And I'm going to talk about 3 illustrative routes to equity, which we'll call levelling up, levelling down, and zero-sum redistribution. So I'm going to talk through each of those different routes to equity in turn. So this is the baseline situation that I showed you before. Levels of need, higher in population C than in populations A and E, for example. Population D receiving most service, and so population D has the highest supply to need ratio. So the question is, what would it take to get all the other populations up to that same supply to need ratio, increasing levels of supply in populations A, B, C and E so that they had the same supply to need ratio as population D? Well, it would look something like this. That's the amount of extra activity we have to deliver. No additional activity for population D because they already have the highest supply to need ratio. Considerable increases for population C and smaller increases for populations A, B and E. And if we were to do that, then we'd all the populations would end up with the same supply to need ratio at the end. So for me, this is what levelling up means. It means bringing all populations up to the highest current level of supply in a population. It's attractive in lots of respects, which is why it's got a lot of political traction, but it does require considerable additional resource, and it's not easy to bring additional resource online quickly. So you might have an ambition to level up, but it's impossible to do that tomorrow because it takes a long time to bring the additional activity online, to recruit the staff, to build the new theatres that we would need to deliver that additional level of activity. The next route to equity is levelling down. So in this same scenario, we note that population C has got currently the lowest supply to need ratio. All the other populations have a higher supply to need ratio than population C. So the question is, what would it take to bring everyone down to population C's supply to need ratio? That would mean something like this: big reductions for population D, more modest reductions for populations A, B and E, and no reduction for population C because it already has the lowest supply to need ratio. And that would bring about this pattern of activity. You might ask, why would we consider levelling down? But remember that during COVID, we did exactly that. We reduced activity deliberately, intentionally, but we didn't do it in a fair way. We did it in a fairly random and haphazard way and actually led to increases in equity. And we also do it every winter. Every winter we cut back on elective activity. And the question is, are we doing that fairly to bring us closer to equity, or are we doing that more randomly or systematically biased fashion? And we also do it for procedures of limited clinical value. We might say there are certain procedures we actively want to reduce the level of supply of. How are we reducing those types of activity? Are we doing it systematically to achieve equity, or are we doing it in a more haphazard fashion? So we often want to level down. We often want to reduce activity. When we do that, we should be aiming to level down when we take that approach. The last strategy I wanted to run through, or the last route, is called zero-sum redistribution. And the idea here is that, can we get to equity without changing the level of overall activity we deliver across the 5 populations together? So here we take the population weighted average level of supply to need ratio, and we try to get everybody to that position. So currently populations A, D and E have a supply to need ratio above the population weighted average. Populations B and C have a supply to need ratio below the population weighted average. What changes in supply would we need to bring everyone to that population weighted average level? that would look something like this. Increases in supply for populations B and C, reductions for the other populations, and that would bring us to this position here. So this solution, this route to equity, is financially attractive, and it has fewer operational constraints because you're not increasing in total the overall level of supply. All you're doing is redistributing it across populations, but it's politically challenging because it means removing care from some populations who are very well served at the moment and delivering that care to populations who are currently underserved. So you can imagine why this sort of solution might be more difficult to persuade people of. The people who will see less care as a consequence of this strategy are usually pretty well politically connected and politically active people. So it will be challenging to get approval for this sort of approach. So I've outlined these three routes to equity, but they're just three of many potential routes to equity you could take. They sit on a continuum, and you can get to equity by increasing or decreasing activity as much as you like, but you do need to add or subtract or redistribute activity in a very particular way to get to equity. You can't do it in any old fashion. You need to do it in a very particular way. And just to, again, show you how that might look, I'm just going to play this little, oops, there we go. So you can see that all of these different routes here playing out will give you different ways of getting to equity, but they all require a very systematic approach to increasing or reducing activity. So this would be zero-sum redistribution, for example. This is levelling down. This is a strategy that's even more reducing activity, even more than levelling down, but it still brings you to an equitable solution. And we have other solutions on that spectrum as well. So one thing to note is that if we understand the current pattern of supply, and that's usually well understood in the health service, we know how we distribute our services, we can quantify the numbers of procedures that we deliver to more affluent or more deprived areas, and we know the pattern of need, then we can work out how much additional or fewer activity we need to deliver to each population to achieve equity at some point on that spectrum. So we can quantify levelling up, we can quantify levelling down, we can quantify any other route to equity that we might want to consider. But here's the rub. Estimating distributions of need is quite challenging. It's not an easy thing to do. If you want to do it for a specific procedure or a small number of procedures, then it's certainly feasible, and that's what we did in our previous report. We looked at 4 specific procedures in detail. But doing it for all the imaginable hospital procedures, many hundreds, probably thousands of procedures that are out there, I can't imagine ever getting to a point where we'll know the distribution of need for each of those procedures in detail. And there's a question there about whether you just stop and give up at that point. Well, we thought it was worth having a go at trying to produce a method that allowed us to estimate equity in the absence of detailed need models for each individual procedure. And we set out that approach in the appendix to the report. It's not perfect by any means, and we welcome contributions from others to improve it, but we wanted to make a start on that journey so that we can start to quantify some of the changes that we would need to bring about equity. So what would it take to deliver equity via these different routes? Well, first of all, our estimate is that to level up activity within each ICB or STP across deciles of deprivation, you would need to deliver about 2 million additional procedures, which means an increase of about 10%. Modest, I suppose, in comparison to the overall objective of 30% increase, but still incredibly challenging given where we are today. And remember, it's not just sufficient to increase activity by 10%, you've got to increase it in a very particular way, targeted at particular populations to get to equity. Levelling down would mean a reduction of about 1.8 million procedures, a 9% reduction in procedures. Remember, we saw an even bigger reduction to that during the COVID period, and we see reductions, 5 or 10% every winter as well. The zero-sum redistribution scenario doesn't require any additional procedures, but it does require us to redistribute about 5% of procedures from more affluent areas to more deprived areas. What it would look like, the 3 scenarios would look like with respect to the 10 deciles of deprivation. So to level up, you would need to increase supply by about 23% to the most deprived areas. People living in the least deprived areas wouldn't see any increase in supply. If you were levelling down, you would need to take about 70% of activity away from the least deprived areas. Zero-sum redistribution sits on a sort of middle ground between those two scenarios, increasing somewhat supply for the most deprived and decreasing a little bit the supply for the least deprived. We can also quantify what levelling up or levelling down might look like across the 11 ICSs or STPs in the Midlands. We'll note that to level up in the Black Country will require an additional 30% of activity, so really challenging target there for the Black Country. More modest increases required for places like Northamptonshire and Lincolnshire and Hereford and Worcestershire. And that's to do with the baseline level of inequities within those areas. But you'll note that every single one of the areas is below the 30% target. So if the 30% target is achieved across the board, and it's done in a deliberate fashion to address equity, then by 24-25 we could be in a position where we have an equitable distribution of supply. That's within our grasp. It's within our gift, in fact. If we increase supply by 30% and we do so in a targeted fashion, then we can eliminate those inequities that we've seen as they set out in the previous report. But the question is, what do you do in the meantime? We're not going to get to 30% increases overnight. So what do you do in the meantime? Maybe levelling up is not feasible tomorrow, but maybe something more like zero-sum redistribution is something we have to start with in the next few years. We can also quantify the additional procedures that we'd need by procedure type, and these are a bit more than the OPCS4 procedure chapters. I've broken it down a little bit more than that. But you can see the biggest, in absolute terms, the biggest increases in procedures required for conditions relating to, or procedures relating to the eye, chemotherapy and high-cost drug and diagnostics. Relatively speaking, rehabilitation is the most unequally distributed of our services, and you'd need to redistribute about 30% of rehab or increase supply of rehab by about 30% to level up activity in that particular domain. So that gives us some sense of what we need to do to get to equity, the types of procedures we need to do, which areas need to focus more on this issue, which populations we need to increase activity by, and by how much. There are estimates, but I think they're useful starting points for this process, and maybe a little bit moves us on a little bit in our thinking compared to the previous report, which kind of just described the problem. So the next point I wanted to talk about was about what interventions might be available to STPs and ICSs to address the problem. So we spoke to lots of people, read lots of papers and strategies and policy documents to see what interventions are being proposed or developed to reduce inequity in planned hospital procedures. And we've collated those ideas here. It's, to be honest, a bewildering set of options that face an STP and ICS. And I think this is part of the challenge, that this is part of the reason why this is such a difficult issue to address. I'm sure there are many more that we haven't found, or different ways of describing the same things in different ways. But it's an attempt to try and scope the range of options that might be available to an ICS or an STP. And we've done a couple of things. First of all, we've tried to group those strategies by their point on the pathway in which they intend to intervene. So the dark green boxes, they attempt to reduce inequity by improving identification and referral of people from more deprived areas. Then we have interventions which are aimed at improving pre-treatment assessment and management of patients from deprived areas. That the sort of turquoisey colour, they're about decisions to treat. How can we improve decisions to treat for those people living in deprived areas? The light green boxes talk about waiting list prioritisation methods. And at the end, we talk about treatment accessibility. How can we improve accessibility of treatments to people from deprived areas? And what we've done in the report for each of those boxes is try and describe briefly what the evidence base is, although I have to say the evidence base is pretty poor for most of these interventions with respect to equity improvements. I mean, they may have, there are papers which, for example, describe the benefits of, outpatient reminder systems, but they don't tend often to talk about the impact on equity. Given that's the case, we also said, well, what's the theory sitting behind each of these interventions? Is the theory sound? Does it add up when you subject it to a little bit of scrutiny? And finally, what challenges might systems face when using these specific interventions? Now, in the report, we spend maybe half a page to a page on each of these, so it's not a huge amount of detail, but I'm hoping it kind of brings into one place what we know about opportunities to try and reduce inequities. And all the references are given, so if you want to follow up on each of those, you can do so. So this is what an SDP or an ICS are faced with. They've got this choice about how do we get to equity, what's the route we take, and we've got the choice about what of the various interventions do we select and pursue. We can't do everything in an ICS. You can't possibly do all of those different things in an ICS. You have to prioritise somehow your efforts. So which of those things should you focus on? These are the two questions: the route to equity and which interventions should we prioritise. And what we've tried to do is break that process into two stages. First of all, there's a job of setting the strategic frame. And then we go on to say, what's the process of developing a detailed strategy to address this issue? That process, setting a strategic frame, is something that the ICB board, we think, needs to take responsibility for. Once it's done that, it can pass the job of developing a detailed strategy onto subject matter experts. And now, if you already have a strategy in place, so I'm going to take you through what that process looks like, a suggested process for working through those two steps. If you already have a strategy in place in your ICS, I wouldn't recommend, in fact, I suggest to ignore the remainder, because it's just going to distract you. It's hard enough to settle on a strategy. If you've settled on one, pursue it. Don't get distracted by this process. But if you're still in the process of working through that, I think this might be useful. And the offer from the Decision Support Network to each ICS is that we'll run, if you want us to, structured workshops with your ICB board to set the strategic frame and to guide a set of subject matter experts through that process of developing a detailed strategy. If that's something that would be useful, please let us know. Karen Bradley is going to be leading that process for us and helping boards and subject matter experts work through that process, if that's something that would be useful. So setting the strategic frame, how do we do that? So you'll remember this diagram. We can get to equity via a range of routes on a continuum. We can think of that as getting to equity by either increasing our activity costs or decreasing our activity costs. But getting to that point doesn't come for free. You have to invest in interventions to bring about those changes. You have to invest management time. And so aside from the changes in your costs associated with increasing or reducing the level of planned care procedures, you've also got some transformation costs, and they're always positive. So if you're in the right-hand side of this plane, you've got your transformation costs, all the interventions, the management time to bring about equity, plus the cost of increasing activity. If you're on the left-hand side of this plane, then your transaction costs will net off against reductions in activity. And there'll be a break-even point at that point where your transformation costs equal exactly your decreasing activity costs. So if you're in this green zone here, you've got to find some additional funding to resource your plan to get to equity, both the transformation costs and the cost of increasing activity. If you're in this green zone, this turquoise zone, then your plan will make a net saving if delivered. And I think it's the ICS board's responsibility to set out where on this plane it wants to be. What's its strategy? Does it want to get to equity by increasing or reducing its activity costs? And how much is it prepared to invest to try and get there? And we think it's the job of the ICB board to set out the answer to that question so that it can set the frame for others to go away and work on the detail. But let's talk a bit about working at that detail. And we're going to be using an approach here called the strategy table, which is one of the components in the decision chain that's come from the improving decision quality training that Mohammed and Fraser and colleagues have been working up and delivering over the last few months. So the idea is for each potential point of intervention, and we're just showing here the identification and referral section of the strategy table, what might a mild or a wild solution look like? The idea is you set out a set of options with regard to each intervention, which takes you from doing practically nothing to something really substantial, and some midpoints on that spectrum. We've set out 3 options here, just illustratively, to guide your thinking, but you'd want to develop your own strategy table, I guess, if you're doing this locally. So, for example, for the decision coaches, one option is that you don't do anything, you just stick with whatever you're doing at the moment. You might want to pilot decision coaches in your area, or you might want to go for a full rollout. Similarly, with targeted case finding, you might want to just carry on with the case finding that you're currently doing. You might want to do some targeted case finding for selected conditions, or you might want to adopt a really comprehensive approach to targeted case finding. So for each of the potential intervention points, we set out how you might address that question, from doing nothing to doing something really quite substantial. This might be the full strategy table for all of the 20 potential interventions that we identified. And the job of designing a strategy is to select your positions on that table. For each of the 20 intervention points, which of the 3 options are you going for? Do you select something like this, for example, or do you select something like this? And I won't do the sums now, but I'm sure you could work out between you know what the number of potential choices there are here, what the number of permutations of selecting one of 3 options across 20 or 21 choices. It's really quite staggering. It's not feasible for an ICS to consider every single combination of interventions or strategies that might be developed from this table. So how do you go about selecting a credible strategy? Well, you do so by basing it on a theory, and we're going to set out some examples of that now. These, again, are just illustrative. You'd want to develop your own strategies. You can take the ones we've suggested, but by all means, but you might want to think about your own strategies that you could develop. So one strategy, sort of illustrated by this diagram, it shows which selections we've made across those 20 choices. One strategy might be that the way we get to equity is by privileging and championing better decision making between clients and service users, patients, and their clinicians. How do we get to a position where the decision making between those 2 people is improved? And if we were to do that, we think that that would lead to greater equity. That's our theory of change. So you'd favour those interventions which we're going to build on that theory. And there's a few interventions in the table which would fit well with that. Our second sample strategy, again, these are just for illustration, might be to say, well, look, the future's digital. What we need to do is put all our eggs in that basket, really try to get the digital technologies working for people in deprived areas. And if we were to do so, we could use that to try and address the gap between more affluent and more deprived communities in terms of access to planned hospital care. There are some interventions in the table which are more aligned to digital interventions. Let's go for those ones. That's our strategy, to go for a full set of digital interventions to address this issue. Sample strategy 3, its theory is that if we can align financial investments with our objectives, then we'll get to equity. So let's follow those interventions which are more about redistributing resource, incentivizing providers to work with more deprived communities, taking out some of the cost burden for patients, for example, associated with having planned hospital procedures. Sample strategy 4, we've called Be Practical. Participating in the planned care system for people living in deprived areas with complex lives is challenging. It's complicated. They've got to fit it around lots of other responsibilities, earning money, caring responsibilities. Travel, for example, is not necessarily straightforward. Out-of-pocket expenses. Let's just try and deal with some of those things. Let's try and make it as easy as possible for people from deprived areas to work through the process by just addressing some of the practical barriers to participating. And the last of the strategies we were suggesting is one we call Get Upstream, which puts all your eggs in the process of addressing the problem earlier on in the pathway as you possibly can to try and make sure you get ahead of the problem. So having developed a few strategies based on theories, the question is how you might select from between those. And we've suggested 5 criteria, which I won't go through in detail, but is the strategy compatible with the strategic frame, for example? Is it coherent? Is it easy to communicate to your staff and your stakeholders? Does the theory stack up? How feasible is it? How much might it cost? How much management time might it cost to implement it? What are the political challenges, etc.? And to what extent might the strategy be compatible with public perceptions and public views? Do you think that's what the population want from you? And SDPs, ICSs might want to consider the use of multi-criteria decision analysis, which is a fairly well-developed technique to rank and order the provisional strategies according to these criteria in some systematic way, so that you can show explicitly how you come to your decision about your preferred strategy using that approach. So that's the stage of designing an intervention. And as I said, the Decision Support Network are happy to work with ICS to guide boards and subject matter experts through those two processes in structured workshops, if that would be useful. The last section of the report focuses on measuring progress. And what we've done in this chapter is set out some potential metrics that you might use to measure your progress. We suggested quite a lean set of metrics. We're talking about measuring the relative index inequality in a range of indices that you might use to monitor progress. There's many more metrics you could add in, but I think there's a value in being a little bit focused in your approach here. They're going to be either averaging across lots of points of delivery and specialties from procedures, for example, or they may be illustrative of other procedures. But there's a theory behind this set of metrics that we're proposing. And we set a set of principles for how you might go about monitoring them as well, making sure that, having developed your monitoring mechanisms, that somebody is there ready to receive them. A group or an individual has responsibility for reviewing and making decisions on the basis of changes in those metrics. We're recommending use statistical process control just to stop, to make sure that you respond appropriately to whatever the information is telling you, that you don't react unnecessarily to chance occurrences, that you can distinguish between special and common cause variation. And we advise against setting targets. We think they do more harm than good on average in performance monitoring terms. And we've also set out a little bit about the methods that you might use, how you might measure the relative index of inequality, case mix adjustment, etc. in the report. So that's the report in essence. That's what we, that's the content of the report. It runs to, I don't know, 80 or so pages, but I'd encourage you to read it if you get a chance. But if not, then we're happy to meet with you again to talk you through the detail. And I'd be really interested in your sort of questions and feedback, if that's all right. I'll back over to you, Rachel, now.
Thanks, Stephen. That was great. Yeah, we do have a couple of questions which have been put on to Menti, and now I do have an option to either share my screen or just read a couple out. I'll share my screen, in fact. So let's do that. There were a couple of early questions around they couldn't hear you. Oh. So, but I'll share my screen anyway. Oh, we have some claps there. Great. Okay, so as you can see, I think from the screen, there's a couple of early things on people not being able to hear the sound. And for those people, the recording will be on the website, just in case it didn't ever appear. You can see and catch up later. So I'm looking at the first column first, but you can pick whichever ones you like. So someone is very interested in the animations. So was it GG Animate?
It was GG Animate, yes, that's right. Yeah. Well, most of the animations in the presentation were just done in PowerPoint, but the particular leveling up, leveling down one was done within GG Animate. Yeah. I'm happy to send you the code if it's useful.
Okay, so I'm going to pick a couple, then I'll let you pick a couple as well. So I'm going down the left-hand column, and someone has commented on that the strategy table and the reference to wild and mild lingo. I also like that. I think when I first came across that approach, I just think it allowed people to see the solutions more differently. You didn't have to be constrained with a typical range of possible solutions. You were able to sort of be a little bit more lateral thinking about some of the things that you might want to put on the table. I feel pretty comfortable doing that. So I think that's the idea of that. Now I'll choose one more, and then I'll let you choose some. So somebody, I'm going shooting over to the right hand side column. I don't think we're going to be able to get through them all. So someone has asked whether the interventions that you've included in the report were critically appraised, and I think you've said the references are all in there.
Yes, but I should be really honest with the group about the level of evidence review we did here. Given the range of interventions, it really wasn't feasible to do a systematic critical appraisal of all the evidence. I've tended to choose systematic reviews where they're available, and well-conducted trials where they're not. But I simply couldn't make, in the time I had available, a systematic job of doing a literature review here. So I've made a start on it. I hope it's useful. I hope I've not misled anybody in that process. And maybe there is a job to do a more systematic review of the evidence here. And if people would really find that useful, then we can certainly take that back to colleagues in the unit who specialise in that area. I think it would be a considerable undertaking to do a really thorough systematic review of the evidence base across all the different interventions. And also, it's worth noting that there isn't a huge amount of evidence out there to find as well. So there is a question about the value in doing a more systematic approach. I don't think I'm missing a lot. I'm probably missing some important studies, but not a huge amount of important studies out there.
I should think we would collectively welcome feedback from people if they do or are able to add anything to that conversation as well.
Absolutely.
Yeah, I mean, this research could last 3 years, and it would be incredibly thorough and terrible in terms of timing, because things get out of date and people need to take action, and there are targets to achieve. So there's a compromise, isn't there, between the level of detail and the time that people have to make these decisions and put things into action as well. So I've lied. I'm just going to pick on one more thing, and then I'm going to allow you to choose some 1 or 2 comments. So I'm just looking at this one in the middle here, which looks at how and where do you source the data that helps us estimate the distribution of need. A big question, and you touched on it.
Well, it's a question I should have anticipated given the group I'm presenting to. So maybe I should have had a couple of slides in what we did there. I have got a couple of slides in. But shall I start sharing my screen again and just take you very briefly through the approach that we took? And you can just before I do, I'm just, this is in the interest of full disclosure, this is something that's still work in progress. It's not ideal, but it's a good start, and we would welcome other people's views on how we can improve on this over time. So let me just share my screen again. Bear with me while I get to the relevant slide. Can you see that chart there? Yeah. So in the previous report, we did some really quite detailed work on estimating levels of need for 4 pathways. We looked at heart failure. The end of the pathway would be something like valve repair. We looked at COPD and lung volume reduction, and we looked at hip arthritis and hip replacements. We also looked at cataracts, but that, I guess, we were less comfortable with that one of the 4. So just focusing on those first 3. So for those 3 procedures, and I should say that we weren't working up the need models ourselves. We were relying on excellent prior work done by people at UCL and PHE, for example, who've worked up those need models, who were just applying those. So we do know what the pattern of supply for those are. And so we can plot the need supply ratio for each GP, and we've done that here by 50 quantiles of GP practices by population weighted deprivation. So the most deprived to the most affluent. You see this slope in favour of people living in more affluent areas. People in more affluent areas, the heart failure, more likely to get a valve repair than people living in more deprived areas. So that's the profile of supply to need ratio that we know exists for that condition. And we wanted to compare that to 2 other broader measures of need that we might use to see which of them tracked the supply to need ratio better. So we looked at crude rates, simply the rates of the population, rates in a population divided by its population size, and a directly age-sex standardised rate. And at least for heart failure, crude rates seem to track supply to need ratios more effectively than directly standardised rates. Marginally better, but it is better. This line here is closer analog to the red line than the blue line is. For the next one we looked at, which was, COPD and lung volume reduction. This is the pattern for the supply to need ratios across the 50 quantiles of GP practices. Pretty level for the lower levels of deprivation, but increasing as you become more affluent. Neither the crude rate or the directly standardised rate do a great job of proxying that profile, but I would say the crude rate does a better job of the two. I'd rather go with the crude rate than the directly standardised rate. And this is the supply to need ratios in blue here of hip replacements for people with hip arthritis. Slightly different profile, increasing through lower levels of deprivation, decreasing as you get into the most affluent areas, because these people living in more affluent areas are more likely to pay for privately funded hip replacements. And again, of the three patterns, I would say maybe the crude rate is slightly better than the directly standardised rate of mimicking this pattern here. And if you look at sort of correlation coefficients between the supply to need ratios, the crude rates and the directly standardised rates, the crude rates tend to outperform for any one of those three conditions, the directly standardised rate. So the upshot is that we think the crude rate is a good place to start to proxy supply to need ratios, and crude rates are very easy to calculate across the board. For all conditions, you can calculate crude rates very quickly. You'll see it's not a perfect representation of supply to need ratios, but for those three conditions, it's not bad, and it's good enough at least to us to start making some estimates. So that's the approach that we took. I know it sounds counterintuitive that we went for a crude rate rather than directly standardised rate, but on balance, crude rates seem to mirror supply to need ratios better than directly standardised rates. And I think that's because directly standardised rates only really adjust, but primarily adjust for age, and age will skew towards more affluent areas. Most other risk factors skew in the opposite direction. So we think crude rates happen to better balance between the various risk factors that might exist within a population than just directly standardising for age.
That's interesting.
Okay. That's the approach as quick in summary, but it's set out in detail in the report if that's more useful.
Okay, thanks. We have a question. Jen, you have a question?
Yeah, thank you very much. Yeah, in terms of the crude rates, I just want to clarify with you. For COPD, crude rates is the crude rates of the prevalence of COPD in the population.
No, it's the procedure. So it's the crude rate in this case of, what was it for COPD? Was it lung volume reduction per head of population? It's the procedure divided by the population.
Okay, fantastic.
The supply to need ratio is the procedure divided by the prevalent population, but the crude rate is the count of the procedures divided by the size of the population, not the need population, the total population.
Perfect. Thank you.
Okay.
Okay, I'm just going to share my screen again, and we've only got a couple more minutes, so you can see here, Stephen, there's lots more questions. So what I'm going to do, because we don't have time to go through them now, I'll share all of these with you afterwards, and we can share your responses back to the group after today's session, because I know you wanted a minute just to go through just to mention the fact that we've started the process of selecting the analytical projects for the current year for 22-23. So that's the Midlands Decision Support Network analytical projects for 22-23. And you just wanted to mention that to this group because we want people to contribute, basically.
Yes, so we're drawing up a long list of potential ideas for projects for next year that we'll put to the Decision Support Network strategy group, I think they're called. They will select on behalf of the network. Mm-hmm. So you'll each have representatives on that group. But we want to make sure we've got the right ideas that we put to that group. And so if you've got any ideas or projects that we maybe should or could be working on in the future, please get in touch with me directly and let me know, or via Rachel. Rachel will put you in touch with me. You don't have to have a fully formed idea, so don't wait until your idea is perfect. Come to me as soon as you can. I'm happy to work up the detail of the idea. I just need to know what the germ of the idea is from you, and I'll take it from there and try and develop into something that we can put back to the board. So if there are analytical questions you think are big and important that need to be addressed, that we could do with trying to do once and do well on behalf of the whole network, let me know, and we're happy to add those to the long list. We'd love to hear your ideas.
Yeah, that's brilliant. So I was just reflecting earlier that we do approximately three of these significant analytical projects each year. So we've done pretty much 6 now. This is the 4th one, which we're sharing the results of here today. The report will be out next week, and as I said before, this is the first sort of airing of it, and we'll welcome feedback on what was useful about how it was presented, and if there's anything that you'd like to know more about. I'll reflect on the questions that people have raised on Menti that we didn't have time to go through. So, but all I've got left to say now is it's 12 o'clock, so it's our ending point. Thanks ever so much, Stephen, for coming today and sharing the report with us. I've no doubt there will be follow-up from the report that people will want more detail on, and I think you'll probably be back talking about elements of it in a little bit more detail. I hope that's okay with you.
Of course, yeah.
Brilliant, and thanks ever so much everyone for coming. The recording will be on the website. If you've got anybody here who wants to join the Midlands Analyst Network, just get in contact and I will add you to the list of members, which is about 650 at the moment. So it's great to have you all here. Thanks, and see you again in a couple of weeks.
And apologies I didn't get around to answering all of the questions. I will have a look over them after the meeting finishes and get back to you.
I'll share them with you.
Thank you.
Thanks everyone. Bye bye.